Good afternoon and welcome to our meeting dedicated to the project Improving Cancer Care Coordination and Screening in Latvia. It is streamed in the IARC YouTube channel, and you can access the replay from the same channel afterwards. If you have questions regarding the project, please send them to the emails displayed on the screen and we'll respond to you just after the meeting. My name is Nadia Dimitrova. I'm Public Health Officer at the International Agency for Research on Cancer. I'm coordinating the activities on this project. And now I would like to invite André Carvalho, scientist at IARC and principal investigator, to present the project and the partners. André, please.
Yes. Thank you so much, Nadia. And thanks to all of you that have joined us live today or are watching the video. It is my honor and my privilege to have participate as the principal investigator on this important project in Latvia. I'd like to express my gratitude by thanking all the stakeholders and authorities from different Latvian institutions involved in this project. The IARC staff, international experts include the team from OACI that has been part of the IARC team and evaluators, as well as the European Commission, specifically DG Reform for the funding. Without all of you working together, this project could not take place. I'd like to give some feedback, some background information regarding this project as well. It starts by a request from the Minister of Health in Latvia in 2020 to the European Commission, specifically DG Reform, regarding a technical support for improving their cancer register, their cancer screening, and the design of a roadmap for a comprehensive cancer care network in the country. It's important also to say that all the activities were aligned with the newly launched then European Beating Cancer Plan. Next, please, Nadia. So I also would like just to briefly say how that work, consider the coordination and the management of the project. We at IARC create a secretary that work very closely with the University of Latvia, namely with Marcus Leia and Poland. And with that, we create a steering committee that would facilitate the implementation afterwards of the project, but also with the working group, operational working groups, one in cancer register, one in cancer screening, and one for the comprehensive cancer care network or infrastructure. And we're going to talk about these three main streams today. Next, please. In the end of this project, in the end of the day, what we really would like to see is that this project could impact Latvia by contributing to improvement of early detection of cancer, a better cancer care, and surveillance of cancer that ultimately would reduce the cancer mortality in Latvia. Once again, thank you everybody for being here. I think we can go for the agenda then, Nadia. Right. So we start, and we're going to start now with the institutional greetings, followed by the presentation on the cancer registration finds and roadmap, on the cancer screening finds and action plans, and followed by the comprehensive cancer care infrastructure, and finally the conclusion and the next steps. With this, I think we can stop sharing, and I would like to pass the word to Simon Dras, that we're going to share a video from Mario Nava, that's the Director General from DG Reform, is his video message.
Dear Director Weiderpass, dear ministers, state secretaries, dear colleagues, dear ladies and gentlemen, good morning. I'm very pleased to welcome you to this event. The webinar will focus on the key results of our project supported by the Technical Support Instrument on improving cancer care coordination and screening in Latvia and Slovakia. Technical Support Instrument means tailor-made technical expertise to EU member states to design and implement reforms in different areas. Latvia and Slovakia requested technical support in the context of a growing burden of cancer cases across the EU. Unfortunately, we are all aware of that, as we have many been affected, either directly or indirectly, through friends or family members. This is why the project is so important. Over the past 2 years, we have worked together with you to improve cancer screening, registration, care, and research. We have adopted a comprehensive approach, addressing all levels of cancer prevention and care. We did it with support measures very tailored to the local context, taking into account the specificities of the health system and the particular cancer burden. More precisely, in Latvia, we have provided recommendations to improve the governance and the organization of cancer screening and registration, including the IT system. We have also provided an action plan for establishing an accredited comprehensive cancer center, which would help to improve both cancer care and research. In Slovakia, we have focused on strengthening the quality of cancer screening, including alignment with international good practices. We have worked also on communication in order to strengthen awareness of cancer screening with a particular focus on citizens. Given the extension of the problem across Europe and the common challenges, we are delighted to have enabled the cross-country exchange to the mutual benefit of both member states and possibly other member states in the future. It's also important to note that this project took place in the context of many important initiatives on cancer at EU level, in particular Europe's Beating Cancer Plan and the Horizon Europe mission on cancer. Our technical support complements these initiatives. We work in close collaboration with the respective departments in the Commission, and many of the colleagues are here with us today, and I want to thank them. I want to thank also all those who have actively contributed to the success of this project through contribution in working groups, responses to surveys, and participation in past project events. I also want to thank the colleagues at the International Agency for Research on Cancer and the Organization of European Cancer Institutes. We have had a very productive collaboration with them, and they have provided excellent expertise and advice. We have already seen many promising developments over the course of the project, and I hope that the momentum persists and that you can build on the outputs of this project to tangibly improve cancer screening and care. Thank you very much for your attention.
We're going to continue now, with Elizabeth Vaderpas. She's the director of the International Agency for Research on Cancer. Elizabeth, my pleasure to introduce you. Thank you for being here.
Thank you, Dr. Carvalho. Thank you very much. Dear colleagues and partners, dear friends, it's with great pleasure that I extend my warm greetings to each and every one of you on behalf of the International Agency for Research on Cancer of the World Health Organization, or IARC. Today and tomorrow's event mark a significant milestone as we gather virtually to celebrate the culmination of the Improving Cancer Care Coordination and Screening in Latvia and Slovakia, abbreviated ICCCS project, a collaborative initiative between IARC, the European Commission, and the dedicated ministries of health in Eastern Europe. The objective of the project, which was launched in 2022, rooted in this comprehensive framework, has been to forge strategic plans and roadmaps in collaboration with our international partners aimed at significantly reduce cancer mortality in Latvia and Slovakia. This journey, embarked upon with the commitment to advancing cancer control efforts, aligns with the overarching vision of Europe's Beating Cancer Plan. Today's focus is on Latvia. Cancer remains a significant health challenge in Latvia, with the country grappling with various forms of this complex disease. According to our estimates, in 2020, there were to over 12,000 new cancer cases and almost 6,000 cancer deaths in Latvia. The incidence of cancer in Latvia underscores the importance of strategic interventions and collaborative efforts to enhance cancer control and prevention. Over the course of this initiative, our collaborative focus has been on building the vital capacity for population-based cancer registration, enhancing information systems to identify and invite eligible individuals for screening, establishing robust frameworks for monitoring cancer screening programs, and aiding oncology centers in establishing a roadmap for comprehensive cancer care infrastructure. As we convene today, we are not just reflecting on the achievements of the project, but also setting the stage for a profound impact on cancer prevention and treatment in this region. The recommendations that will be presented by our experts during this event are not merely insights. They are invaluable resources that will guide authorities and stakeholders in fostering a more effective and coordinated approach towards cancer care. I would like to express my sincere gratitude to all the participants, experts in cancer screening, in cancer registration, oncologists, policymakers, patient advocates, and researchers for your unwavering dedication and collaborative spirit throughout this endeavor. I would also like to thank DG Reform for their leadership and their generous financial support to this program. Your collective expertise and commitment have been instrumental in shaping the outcomes we celebrate today. In the spirit of shared commitment and continued collaboration, I welcome you to this occasion and look forward to the insightful discussions and recommendations that will propel us forwards in the ongoing pursuit of excellence in cancer care in Latvia. Thank you very much, and the floor back to you, Dr. Carvalho.
Thank you so much for those words. I'd like also now to invite Aiga Balod from she's the Deputy State Secretary on Digitalization and Change Management Issues from the Ministry of Health of the Republic of Latvia for her introductory words.
Thank you very much. And I think I could conclude with one simple sentence. I stand in awe of what has been done over a year. When I joined this group, there was a word said to me, and this word is CANCER. What does it mean for this group? It's clear, it's cancer. And it's what the project has been dedicated to. For me, those letters mean courage, ambition, network, care, emergency, and research. Why do I say so? The courage that I've seen in this team, and I thank all of those on the other side of the screen, and I wish you all could be here, because I see the festive eyes of the participants, yet so much to do ahead of us, and I see the ambition to go forward, and the next steps already have been envisaged, and collaboration will just continue. The network, I wonder if anybody has not found an additional network member within the 2 project years. Care, I think that's that binds all of us. Better care for our citizens, better understanding how we can provide it. Emergency, the need for it, I think it comes all over, and expectations from us are tremendous, but we will keep on pushing in as we see the pathway. So I would say thank you a lot for setting the milestones. Thanks to my colleagues, some of the milestones already have been reached, and it has also been a great well of inspiration to see how many colleagues around collaborate over the same issues. I think we also have got a better grasp on our analytics, on data sets, on systematization of information, and we have also homework to be done there. At the same time, at the end of the day, I think we all are aware of the major role of screening and monitoring that will never cease, though it will change its angles. I'm also looking forward the methodological centers and the Cancer Excellency Center that is sprouting, not yet there, but we will do all the best and we will find the resources that it flourishes. Again, I would like to refer back to those couple letters, CANCER. When I talk to general public and my colleagues in the public sector, there is fear related to this word. I would say that you all have knowledge here. Knowledge, new tools, new opportunities, how to beat the cancer on the EU level together. And I would express my total gratitude. And also, not only gratitude, but I also hope for continuous cooperation. Professor Leia has been putting together puzzles. And I don't know if he likes puzzles, but for us, the cancer treatment plan, cancer situation in general has been very segmented and puzzled. He has been the one who's been pulling it together. And I think we now start seeing the pattern. I wish that in 2 years, in a year even, the pattern would become more brighter and others outside our circle would understand it. Thanks a lot. And I still see that we will continue cooperation. Thank you.
Thank you so much, Ida, for those encouraging words. I'd like to pass the floor back to Nadia so we can continue with the agenda. Nadia, please.
Thank you, Andre. With this good start of the meeting, we now move to the session on cancer registration. And I now invite Ariana Znauer to present the improving of population-based cancer registration in Latvia. Ariana, please.
Thank you, Nadia. I will share the screen. Okay, can you see my screen?
Yes.
Yes, we do.
Okay, thank you then, Nadia, for the introduction, and good afternoon, dear colleagues and listeners. Very nice to see the Latvian team again. I will present the work on the work package 2 on improving population-based cancer registration in Latvia, which was led by myself and my colleague Les Mary. So the population-based cancer registries are really a cornerstone of cancer control, as they are the only mechanism to obtain population-based data on incidence and on survival, and thereby be able to plan, monitor, and evaluate the activities in cancer screening and cancer treatment. Latvia does have a long tradition of cancer registration, and the cancer registry was established already in 1993, and then later on it was held by different institutions, and then since 2018 the database has been managed by the National Health Services and also shared with the Center for Disease Prevention and Control. However, there were certain challenges, in particular in data quality and timeliness in the recent period, but then also there was a really high degree of interest among different stakeholders in the Latvian population-based cancer registration and broader in the cancer community for the registry enhancement and improvement. So the ICCC projects aim to provide recommendation to improve the data quality and accessibility and use of the population-based cancer registry data. And we have formed and worked with the operational working groups towards all these activities to advance the registry. So our main output was the action plan for the improvement of cancer registration system and cancer registry data quality. And then we have been working together with the working group across these different tasks, from situation analysis through the site visit and then later follow-up site visit, providing detailed report and recommendations, and working with the group through a series of meetings to draft a time-bound action plan, and to then that was approved by the steering committee of the project. So I think really this was such a rewarding example of networking and working together within this operational working group framework that was the members were proposed and identified by the leaders of the project in Latvia, and we have covered all the required cancer group members' profiles, because we were looking to identify people with expertise of epidemiology, with database managers, with IT experience, then also cancer registry operations skills, as well as then the representatives of different data sources such as clinicians and pathologists. And then, so we had about 20 working group members with different experts and 2 co-chairs, one from each of the 2 main institutions. So Jana Lepiskone from CDPC and Aris Kasparans from NHS. And then on IARC side, my colleague Les Mary, myself, and Aline Mafra until August 2022. And we held 6 meetings first, and the latest ones were online, and in between we were working virtually, but this was a continuous process, so the group was very busy in between the meetings as well. After the first site visit that took place in March 22, we provided detailed report and recommendations on governance, on training and staff needs for the registry, and detailed technical recommendations on operation procedures in terms to align them with international standards. I will not go much into technical details, but at the time of the first site visit, of all the different necessary sources of data for population-based cancer registration, the registry was not receiving that certificate data they were missing, and also pathology laboratory data were not included as an independent data source. However, the main challenge was with the cancer registry governance that was divided between 2 institutions, one of them NHS, which kept the IT system, the registry software, as well, and was responsible for data collection. And on the other side, the CDPC, that was tasked with data quality control analysis and reporting. However, there was very little communication and feedback between the 2 institutions, and what was most limiting is that they couldn't exchange personalized data. That meant that CDPC was actually not able to perform its role in the data quality control, to be able to check then individual data, ask for feedback at data sources, and so on. Whereas the NHS could not receive mortality data and keep them in the registry database. So we proposed this governance scheme, with then the 2 institutions being co-responsible for the cancer registry, and then with the oversight of the advisory committee, with the experts from the both institution and other stakeholders, and also with the defined role of the registry director, and the possibility to exchange personalized data. Then the CDPC would keep these roles of these different registry operations, whereby we also provided detailed recommendations. And what is then also very important is to establish and define this operation, but also document them in the standard operation procedures manual that would then contain both the more international practices, but also document the local procedures and operations in your system. So after having the recommendations, and we also had some main overall conclusions together with the screening team following the visit. So broadly, we saw that both registry and screening programs were already in place and operational. And then within the ICCCS project, our task was to work with the national stakeholders to then further develop the functionalities and linkages, to put the governance in place, and to work on enabling exchange of data between the institutions, and also recommending a training program and quality assurance procedures. So we worked together with the working group led by the two co-chairs, and throughout this series of meetings to discuss first the report and recommendations, and then to really translate the recommendations to a time-bound action plan, where we outlined the different activities, also with a time frame, but also specifying who were the responsible actors or institutions for each of the recommendations. So it was a collaborative effort with the working group, and then they are also listed by name in the document. That then the date that we had was November. The activities were planned as from November 22. And then this is a proposed timetable of the activities. Of course, it goes into much more detail in the document. So when we visited for the second follow-up visit in March 23, we have seen that some of the activities have already been accomplished, and the other activities were on track. So now coming broadly to what we see as the next steps, and this is quite generic, whereas my colleagues from CDPC and from NHS following my presentation will tell you more details about what they have achieved and how they see the next steps from their side. So broadly, they think the main challenge really was the governance, and further strengthening would be really important, alongside increasing the stakeholder engagement within the Registry Advisory Committee. Then the new cancer registry software has just been launched. We will hear about this in the next presentation, and it's now important really to fully deploy it, and then to map the cancer registry operations, including the work with the new software, and which will then be able enable the team to better estimate the resources which then need an adequate resource allocation. So hereby I would finish my presentation, and just to mention that the work belongs within the scope of the Global Initiative for Cancer Registry Development program, and you can find more information then on our website here. So thank you.
Thank you very much, Ariana. Very informative presentation. I would now ask the colleagues from the National Health Service who were responsible for the development of the IT infrastructure for the cancer registry to show their progress so far. So I give the floor to Gundars Minaugo, please.
Yes, good afternoon, colleagues. Hope you hear me well. Yeah, so I will focus on our achievement on population-based cancer registry. It's phase 1, what we have done so far. I apologize for some technical things I will mention, so probably sometimes some bit more technical than it's needed, but I will tell you the story how it is built and what we have right now. So at the beginning, when we started the project, we envisioned that it will be built in long term, so it's 3 phases. We will start with population based cancer registry, which we find more beneficial, and we will get quicker results for a shorter period of time. Then after that, main focus will be on screening registry and clinical registries that requires more and more effort will be afterwards. So currently, we focused on population-based registry, and we have a good result on that. The population-based registry will involve some basic information for statistics, and also little bit more already, some small clinical data that also will benefit for statistics and so on. There was a couple of goals what we have set for ourselves. All were based on the issues we have with our current registry. So we understood that data coming in was with a big delay, and also the quality was not good enough for statistics and for planning or politics on this area. So the main goal was to improve that and increase level of structured data what we can have in the registry, so we can also compare this data both locally and internationally. So it was one of the goals. Then, of course, to speed up the process when data come in the registry was also a big goal. So we introduced this principle enter once in our process that still has a lot of work to do, but we go to that direction that all data should appear in registry as soon as they appear in the system. Also, technically, we found this is the right time to introduce new technology, new standards, and also software should be built in a new way, because the old application causes a lot of issues in the core system. So at the end, working with different work groups, what was mentioned before, we came up with a data set that is agreed in different parts. So at the end, there is more than 40 new classificators built in the system based on SSCO 3.2 and TNMA classification. So we can move more and more structured data over there. API principle that every hospital information system can integrate with this registry. So there are built a lot of APIs based on FAR standard and its profiles. So all profiles are defined and can be used to extend and integrate in the hospital information systems. Also APIs for statistics, for BI tools. As we understood that the hospital information systems will not be in place already, so we built some solution to start use this registry as soon as possible. So we introduced a cancer patient card for practitioners, where they can register. They can now see all the data that are in the registry in easy way and update and add new data over there. Because it requires some regulation changes, that we also have done. And additional, there is a now workspace for CDPC. It's a port where look at data and ensure that the data is in good quality, good shape, so they can check, monitor, and add also some patient cards if the diseases are found after this. So it's also good for them. Quickly, I mentioned FQR standard guidelines. I will skip probably this technical part, but in a general, it's a standard where we can internationally and locally integrate with different systems and with the same that is built in different programming languages. So it's, we can use right now and quickly integrate those. So it's built with different data blocks, different profiles. We choose for this cancer registry. Right now we use this 5 of them, but it can be actually extend and use other ones. So we are now focusing on patient profiles. Then is the 2 ones for diagnosis. It's a condition. We can see different data sets from conditions for diagnosis. And all observations data sets also are structured. All treatment, both physical involvement and also medical statements are now structured and can be used to exchange. At the end, yeah, data model looks like this. It's a part of all of that. We will not go deeply into that. Quickly, I show some impressions how the screens look like. So the practitioners can use the same e-health system that they used before. They have a new menu item that will lead to our new cancer patient card in the system. As you can see, it's built in a new technologies and new look and feel. So yeah, it's one of the two main new modules that will introduce new standards and new technologies in the future. So yeah, new cancer card, as I mentioned, has different parts. Yeah, basic person information, information about diseases what the person has, and also all treatments will be in the same place. When we go deeper in the in the disease card, so we can see that there are a lot of fields. All the structured, all has a drop-down menus, and a practitioner can easily find what is how use also the name classification treatment also has. When we go to the treatment, then for every treatment also there are a lot of structured fields that we can enter and then see afterwards. Yeah, quick examples for therapies. We have some drop-down menus where you can choose and then for CDPC, as I mentioned, there is a workplace for them. They have a different entry point, but also they have the same look and feel system portal in place, so they can easily find all the cards that is entered, see their statuses, check statuses, approve, disapprove, communicate back to the practitioners to change if something is not correct. Other thing what we got there and what we found out that all history data also should be in the new patient card, a new registry. So it was also big job what we have done so far. We analyze all data and convert them that they can be used in a new system. They can be shown in the same fields and can be added also and added more data that is required for those data for those cases. As a result, all the data what was in the old system is converted. All can be seen in the new registry. We built some additional classifiers to see also to structurize those data and that can be used in the future. So then the CDPC and the medical practitioners right now can see all those history data, can add also and create those cards that is based on the old diseases. I didn't mention it, but right now we have a big gap with old card that is not entered in, so they have this opportunity to extend the registry. Additionally, all the classifications is translated to Latvian regulation, as I already mentioned. Also, there's CDPC colleagues have provided some education for practitioners, and we are already started using, and most important, population-based registry is live. And as I checked today in the morning, already more than 200 cards are entered. So people are working, and that's a good thing what we have right now. This year we will continue to add some additional elements to the registry. There is a requirement to add some additional information about green corridor, yellow corridor, about screening dates, and so on. So And most important, we should work with the hospital information systems to support their integrations, and that probably is the most important goal for this year. And of course, phase 2, that's probably our next speaker will talk about that. And yeah, that's probably short of me. And I would like to thank you, everyone who participated in the project, who helped in the work groups and helped us achieve this goal. So thank you very much.
Thank you very much, Gonders. It seems you have laid a very good foundation for the further development of the registry. Another important stakeholder in cancer registration in Latvia is the Center for Disease Prevention and Control. So now I invite Zane Baltane to present their role in this. Please, Zane.
Good afternoon. Can you see the presentation I'm sharing? Thank you. My name is Zane Baltane, and today I will present an overview of implementation status of the cancer registration recommendations in Latvia according to Project Action Plan. My presentation consists of 3 parts. First, I would like to give you an overview of implementation status about short-term, mid-term, and long-term recommendations. Next, I will focus on ongoing activities and next steps, and finally, I would like to highlight what CDPC admits as the main points of project benefits. First, let me start with short-term recommendations. And according to governance issues and responsibilities, the result is that the Ministry of Health working group has been established. It means that responsibilities for CDPC and the National Health Service have been defined, and changes in legislation have been prepared regarding CDPC rights for personalized data and also about death certificate only cases. But changes in legislation are not approved so far. So cooperation agreement is signed between CDPC and the National Health Service, and the aim is to ensure the quality and completeness of data in e-health. So access to personal data, CDPC has from July 222, and access to cancer patients' hospital discharge data has from July 223. Now we are moving to midterm recommendations. So we have identified the cancer cases notified by death certificates that are not covered in cancer registry. And these cases are compared with National Health Service hospital discharge database, and the information was sent to hospitals for data input. However, cases which are not found in hospital discharge database still not covered in cancer registry. And as I mentioned earlier, we are waiting for rights in legislation. Following results to this recommendation are that we have legislation regarding mortality data linkage in e-health system. So we have revised and defined variables needed for cancer registry according international cancer data protocols and international cancer research organizations. And also cabinet regulations are approved, which means that from 1st of January this year, we have new cancer patient form. And we have implemented international classifications according international data submission protocols, for example, ICD-0 3.2 and TNM 8th edition. And also new classifications are implemented, for example, international classification of childhood cancer, Ann Arbor, Lugano, etc. Regarding training for cancer registry staff, 2 training seminars for hospitals were provided. Physical meeting for 5 specialized hospitals and a webinar for other hospitals. And also video lectures, presentations, methodological guidelines for e-learning are available in CDPC website. Yes, from 1st of January this year, we have new cancer registry web-based software. And also once a week, we have meetings with National Health Service and software developer. So we have revised and updated built-in data quality checks. As Gunther mentioned, we have new monitoring portal for CDPC. It is established for manual data quality checks and for collaboration with hospitals. And I would like to explain a little bit more about document approval process. I think the graph on the left-hand side perfectly shows how it works. So when hospital submit data, then CDPC staff makes quality control and accept or decline document, and which means that declining reason or reasons are given every declined document. But at the moment in legislation, we have no access to process personal data, but we are still waiting for it. And also data exchange is created, the API is available. However, there are still a lack of electronically structured documents in healthcare institutions. About data dissemination and reporting, we have published statistics about year 2018 till 2021, but only as a provisional data. But I would like to point out that we have published age-standardized cancer incidence rates, and they are available from year 2000, and data are available online in CDPC Health Statistics database in Latvian and in English language as well. And thirdly, about long-term recommendation regarding collaboration and networking. So we provide data to international cancer research organizations. In year 2023, we have submitted cancer data to European Network of Cancer Registries and also International Agency for Research on Cancer. In year 2022, we participated in Tampere University Cancer Registration Workshop. And also in previous years, we have participated in international studies, for example, Concord and Eurocare. So this brings me to the end of my first part of presentation regarding implementation status of recommendations. And now I would like to move on next point, which is ongoing actions and next steps. And they are as follows. So legal basis for CDPC data processing rights for personalized data is not accepted right now, but are still in process. We continue to work with hospitals regarding methodological issues. We have planned to provide trainings for GPs and for pathologists, also question and answer sessions, and it is planned in first quarter this year. We also continue to work to finalize data completeness and quality about year 2018 to 2023. And as we have only population-based cancer registry in Latvia, also clinical data will be very necessary for treatment and for outcome measures, as well as for cancer studies. And in Latvia, we do not have cancer screening registry, which is critically important for cancer screening program operation and evaluation. But we are planning to develop both clinical registry and cancer screening registry in the near future. And finally, I would like to highlight what CDPC consider as main project benefits. And they are as follows. First, comprehensive analysis of cancer registry operation has been done. Second, action plan with detailed recommendations, including responsibilities of organizations and implementation timetable has been prepared. Third benefit is that implementation of recommendations was available to start and even reach during project and together with project experts consultation. Next benefit is great experience to work together with high-level experts from international cancer research organizations. And I would like to thank many thanks from CDPC staff members. And finally, I would like to highlight very important benefit, which is improved knowledge about the operation of the cancer registry. So that completes my presentation. Thank you for your attention. It was a pleasure being here today and work together with this excellent team. And I hope you will have gained an insight into CDPC activities regarding cancer registration action plan. Thank you very much.
Thank you, Zane. It is really great to hear that you have managed to implement so many of the recommendations in such a short time, and you have progressed so much in the development of the cancer registry in Latvia. Really great. Now we move to the next session, which is dedicated on cancer screening. I would like to invite the first speaker in this session, which is André Carvalho, please.
Hello again. I'm going to share my presentation. Can you confirm that you have full screen?
Yes, we do.
Okay. So as comment when I started, right, this and also from others, this is a project that was happening in Latvia and Slovakia at the same time. I'm going to concentrate my part of the presentation now on the cancer screening. Right, the request from Latvia was regarding the digitalization and data protection as a way to improve their cancer screening. From the IARC team, I would like to thank Nadia Dimitrova and Iris Lansdorp-Vogeler, that were part as experts for the evaluation and for facilitating the process with the local stakeholders and experts. So as comment, before, I'm going to talk about the work package 3. There are many people involved here. And I would also like to say that the outputs for this particular in cancer screening, outputs was, for us to deliver during the time of the project, a national action plan for implementation of a population-based cancer register and technical specification for a new integrated information system to monitor evaluation and improve the cancer screening program. Once given in hand, the report, with output was expected, and the Latvia government would have adopted the national plan to implement the population-based cancer register program, incorporated cancer quality assurance, and also the tailored information system to monitor, evaluate, and improve the cancer screening program and to support the population-based cancer register has been introduced, and we just saw the presentation, what's happening. And again, congratulations for all that have been achieved in terms of cancer register in the country. So for the cancer screening, the main components that we evaluate was how was the governance and legislation of the programs, what screen tests and diagnosis regarding guidelines and protocols have been implemented, the organization funding and staff to deliver the cancer screening, the invitations and communications with the screening participants, how was the raising of awareness, the data in the IT system, the quality assurance, and the research. I'm gonna just make a comment here that we had, during the project, we had published, these the systematic review and depth consensus on what would be the essential elements of organized cancer screening, where we identified through the process 16 components that goes in the health system building blocks for leadership, governance, healthcare, workforce, access to essential services delivery provisions, and information system quality assurance. And we also use this framework to measure, how well the cancer screening programs in Latvia were established or were implemented regarding those 16 elements. And the way we work was a mixed methods where we did a desk review, looking for policy analysis and all the information that could show us what's happening. We did facility visits to the screening centers, diagnosis and treatment centers to see how the health system readiness for what's been implemented, how ready they are for changing. Also interviews with the key stakeholders, a meeting with the working groups. And on process with that, we did the SWOT analysis, for the building blocks to see how the screening was developed. During the process, also we try to identify, the stakeholders and mapping, by seeing which one would be the relevant stakeholders, understand the power dynamics, forming a cohesive group inside the working groups, but also how to implement the changes, define the roles and resources, the planning, design, implementation, and evaluation of those stakeholders' involvement, but also how they would engage, thinking about the political and policy makers, the program managers, the implementers, and the potential participants for the whole process and how we could improve the cancer register. And with all that information in hand, the findings of the situation analysis and the SWOT analysis was synthesized, triangulated to feed the action plan. And it's very important here to point out that the action plan came basically from the local stakeholders, right? As well as the validation, all the information for us to create the situation analysis and the SWOT analysis, but also the validation of those funds. So this was very much a collaborative effort between IARC team and the key stakeholders in Latvia. And overall, what we saw was three main bottlenecks on the cancer screening. Those are related to governance and legislation, organization, funding, and staff, and the data in the IT system. And the governance, we saw, a lack of a clear governance on the screening program that would allow, the screening program to run smoothly and have a voice and make more policy changes. We have proposed one model, but this was just a proposal, and we have been working, towards, the mid of the projects and on how to try to figure out the best governance model to Latvia. And I know that this is an ongoing effort, and I appreciate, the whole support of the Minister of Health to begin to work on that. The other part that the data and the IT system is quite important is try to understand, the complexity of the participant of screening to navigate the health system. Taking an asymptomatic individual that got an invitation at home and try, to show that person the importance of participating in screening, even when you are asymptomatic, and take that person by her or his hand and help them to navigate until someone that's diagnosed with cancer get to the cancer care that's needed. This involves so many healthcare providers and healthcare facilities that have data. And with that, comes also the complexity, how to bring all this data to a single center, and how to share back so everybody can monitor and track that patients, that participants, because we need to understand that, cancer screening is a path, right? Again, we take a asymptomatic individual, do a test that might be positive, that might lead to a cancer diagnosis, that might lead to treatment. But we need to understand that the possibilities that everything goes well, right? But what we need also to understand is the alternative possibilities, is that the individual gonna not show to do the test, did not got the results, refuse to continue, and how we deal with all this tracking and all this monitoring of the participant in the screening pathway. Going more specifically for the results of our project regarding cancer screening, we mapped that among the 16 components, 9 have been implemented in Latvia, but 7 is still not there yet, right? Those are highlighted here. There was a lack of comprehensive and well-tailored training of service provider regarding specific cancer screening. The identification of the target population and invitation is in place for cervical and breast cancer, but not for the colorectal cancer screening. And we have had some conversations on how we could change that. But then the recall and also, the safe fail mechanism for the non-compliant patients with a screening positive test or a diagnosis of cancer was not there. And we also have been discussing how this could be implemented. The information system with appropriate linkage, at first when we did the analysis, was not there, but there have been changes that have been shown here. And now, the sharing of data is already facilitated with a legal framework that allowed that, respecting the GDPR rules. So we are sharing important data, but still keeping the privacy of the data, the confidentiality of the data as per EU mandates. And in the information system and quality assurance, the quality improvement framework with a responsible team was not in place, and the reporting with indicators, reference standards, and the auditing was not also there. So these were some of the flag things during our view. And if you go a little bit more, what would be the recommendations we saw by what the process that we analyzed. And here I would like to highlight again that this is what came out from the based on the situation analysis and the SWOT analysis, the recommendations. But there is a document, right, that was done together with the local key stakeholders that have the tasks that's needed for the action plan to put those in places. And that report, will be submitted to the Minister of Health as the final report of the project. So these can be put in place. So for the governance and legislation, we saw that, it's necessary to introduce a governance structure for the screening program according to the project proposal, include a cancer screening section in the National Cancer Control Plan, describe the governance structure, the budget, and the legislative framework for the screening program. In the screening test and diagnose, including guidelines and protocols, our recommendation is to prepare and endorse the most recent evidence-based guidelines for all cancer screening programs. And we have been discussed also that, there is what EU publishes as the guideline, but there is always a way to use an adaptation that make to that guidelines and protocols more appropriated for the setting that is being implemented. Regarding the organization, funding, and staff, it would be to prepare the referral pathway between different levels of care regarding the cancer screening continuum. That's what we have been talking about, the call recall, the fail-safe mechanism, how to track and monitoring the participant in the referral pathway. Also here, I would like to highlight, right, that Latvia has the green corridor that facilitates and speeds the referral of someone that's suspicious for cancer. So somehow that referral pathway is there, but how to adapt for them to incorporate all the participants on screening when the screening test is positive. This is the adaptation that we have been talking about. Implementing a training program and a plan and organized training courses for the screening services provider. This is something also that's important to highlight that, was ongoing. We did a extra training of master trainees, for those that in Latvia that would be willing to be the master trainers for training on how to put a training together. And as part of that, they came with some training, for mammography and for colonoscopy. And I hope soon that this could be put in place. And very important to define a budget that's dedicated to training of the screening service provider, as this need to be done on a continual basis. Regarding the invitation and communication, we discussed, how to strengthen the invitation system, how make it more broad, how to use different ways to approach the participants other than just letters. Also to implement a call recall system and the fail-safe mechanism that these, go after the non-compliance. So people that do not attend the screening, or after screening, they test positive but did not attend the next step until rule out or confirmation of the cancer diagnosis. And to prepare a writing procedure for communication with the screening participants, how we can have a better template on that sense. Regarding the data and IT system, it would be the establishment of the screening register at the National Health Services with possibility for linkage with the population-based cancer register and clinical, the hospital-based registers. And we see that these are ongoing efforts, and my congratulations for that, and develop a legal framework that allows the data linkage and the sharing wide insurance and data protection standards, also something I know that's ongoing. Regarding the quality assurance, this would be to create and implement a quality assurance scheme for the screening program based on existing EU quality assurance schemes, and how to adapt that for the local context, but also keeping the core of the quality assurance and not bending that too much. And also how to define, again, the budget for implementing a quality assurance scheme for the screening program. That's very important. Raise awareness would be to prepare the cancer screening specific communication strategy implementation plan, including a monitoring framework, would be to align the raising awareness campaigns with the cancer screening specific communication plan, delivering information to the public on continuous basis, including target communication to vulnerable population subgroups. We have identified some of them during our project. And again, we always be the repetition, right? That all of these needs personnel, needs workforce, needs budget to have investment and awareness. But also we see that the cervical cancer program was able, to raise awareness, that raised the participation significantly, the participation on screening with a budget that was, quite small if you think about the benefit and the impact of that. And we also discuss how research can be, integrated on that. How to proposing to describe a strategy to integrate research in the screening program. So you have more people looking at your data, analyze your data, rising hypotheses, and having more performance indicators analyzed, and probably these, also could improve the program in mid and long term. And to use methods of implementation science to facilitate the decision making on improving the effectiveness of cancer screening programs by implementing pilots, or by any major change in the program, do this as implementation science. What I would like to, towards the end of my presentation, to highlight is that, this project was very much country specific, as also cited by the director of the DG reform. It takes into consideration the local context it includes all the local stakeholders in the whole process, so the ownership is there. So local key stakeholders is providing data inputs and validation, was a hands-on during the situation analysis, during the site visits, during the SWOT analysis, and also in the preparation of the action plan and the roadmap. We see that the technical support instrument from the DG reform is a useful mechanism for countries seeking for guidance on implement changes and evidence-based interventions at their cancer screening programs. Once again, I would like to thank everybody for this, and I'm going to end my presentation here. Thank you.
Thank you, Andre. I really believe that the action plan that you presented is a useful tool for the policymakers and service providers to strengthen the screening program in Latvia. The Center for Disease Prevention and Control has been recently appointed as a manager of the screening program. So now we'll hear from Jana Lepiksone how they are preparing for this. Jana, please. Jana, can you share your presentation?
Just a moment, please.
Okay. If you need help, let us know.
Oh, no, it's okay. Good afternoon. So thank you, Andre, for your presentation. This presentation already pointed a lot of work done, and in my presentation, I would like to just focus on some issues on the way of the improvement of cancer screening program in Latvia. And as the cancer care improvement plan we have in Latvia, and it was prepared by Ministry of Health and approved by government in 2022. And this plan includes also actions and activities on the cancer screening program improvement. And I want to mention some of these activities focused on screening. And this first action is envisages the implementation of measures to inform and educate the public, including prevention and organization of cancer screening awareness campaigns. The second course is development of comprehensive state-organized cancer screening, and this action includes activities in screening program coordination and monitoring management, improvement and strengthening organizational structure, as well as improvement of screening processes, quality and outcomes in cervical, breast and colorectal cancer screening programs. And this second action also includes this activity on DG Reform ICCCS project, and activities from third to fifth actions are some certain activities focused on cervical, breast and colorectal cancer screening programs. And as Andrea already mentioned, we received during this ICCCS project this evaluation of cancer screening program in Latvia, and this project of activities was from the point of international expert raised this importance of process quality and outcomes of the cancer screening program, and not only focused on response rates. And IARC experts within the evaluation of cancer screening program involved also all stakeholders in Latvia, including Ministry of Health, National Health Service Center for Disease Prevention, also professionals and service providers, and we received this wide and very important situation analysis in this and this SWOT analysis that identified not only these weaknesses, but also strengths and opportunities and also threats in our screening program. And as Andres said, these international experts together with national stakeholders made this action plan how to increase this effectiveness, maximize benefits and minimize harms of cancer screening program. And this already was said, but one of the recommendations emphasized by IARC experts from the very beginning of the project was the strengthening of screening program governance. And really, when the project began, there was no one organization that was responsible for the governance of cancer screening program. There was, according to these legislative acts and functions of different institutions, each institution had its own separate tasks and functions in cancer screening. For example, CDPC provided these activities for public education and information. NHS provided invitations for screening, sends these invitations, provides availability of screening services and also payment for these services from the budget. And medical professionals on their own activity, I would like to emphasize it, that it's very important that they, on their own initiative, they prepared and presented proposals to the Ministry of Health or NHS for the improvement of screening. And such a structure didn't ensure coordinated governance and management of screening program. But in the end, as a result of joint efforts, local and international, for persons that were involved in this project since October 2023, our institution, CDPC, has been delegated to manage the screening program. And also some functions are delegated for NHS, and it means that this in the future also we have to work in close cooperation together, all stakeholders to implement this screening program. And according to these recommendations of IARC experts, we will work, continue on the National Screening Committee will be established, and also this Screening Advisory Committee for each of screenings will be created. And but also I would like to focus that work on building and strengthening the screening management team is ongoing, and this under-resourcing is and will continue to be a challenge, both human resources, also finances, etc. So we need to work together in the future. And regarding, I would like to, from the other recommendations that Andrea already said, but I would like to focus and say that one of the most important issues is changing the mindset that the screening program is not just a single test, but process and pathway. So we need to focus on the entire screening process and patient pathway and quality assurance at every stage. And screening is effective only if each of these stages work well. So we need work on creation and implementation of the quality control system, including monitoring of primary and secondary examinations, development of screening pathway protocols, guidelines, and coordination of services, evaluation and reporting of performance and outcome indicators also based on existing EU guidelines and quality assurance schemes. And also very important is auditing of the program to identify and to find out these failures of screening process and find this potential for improvement. And also this that already was mentioned, but it's very important to develop and implement and organize these training programs for all service providers involved in the screening. And last but not least, an important impact on screening program results plays also the communication. And we need to prepare cancer screening specific communication strategy and implementation plan to improve awareness of various stakeholders, patient organizations, community, healthcare professionals. And as an example from Slovenia shows that if all stakeholders and relevant professional groups are not carefully included, then the possible negative opinion can have long-term effect on lowering population participation in programs. So everyone should be included and involved in all this process. And we have to improve also this awareness and understanding of the harms of screening at all levels, both health professionals and public. So everyone should to have this informed consent to participate in screening. And last but not least, that is regarding the data and IT system. And this well-organized data collection and IT system support is required to ensure the successful implementation and monitoring of the screening program. And as already said, we have need to improve this IT system, and we have to make these improvements to our IT system based on existing infrastructure. We have to take into account what we have in place, and then by a step-by-step manner go forward to use what we have and improve step-by-step from this some short-term solutions, what we can do with in first and then step-by-step to achieve this complete screening platform. And this screening register should include all data from all healthcare providers, including data from private sector service providers, not only state-paid services. And in this process, we have to take account also all parallel ongoing IT projects in the e-health system. For example, development of cancer registry or laboratory data module in e-health system, etc. As well as very important aspect is also digital maturity of healthcare institution systems that allow to data exchange between systems. It's a very crucial and important point I would like to say. And in the future, from our point of view, we have to consider also changing this data source from payment documents to the clinical documents in structured data format. And finally, I would say that a close cooperation between involved institutions, our center, National Health Service, and all healthcare providers is required to establish an integrated information system to monitor, evaluate, and improve the cancer screening program. So, thanks to this 2-year project and successful cooperation to all involved international and national experts, we have taken a small step forward, I can say, but to perform the tasks included in this action plan and achieve the goal of screening program, a lot of work and financial and human resources need to be invested in future. And I would like to take this opportunity and thank to all involved experts, specialists, to everyone that participated and gave their input in our common work. So, but I would like to wish all of us also good cooperation in future. We didn't reach the goal yet. Thank you.
Thank you, Jana. A lot of challenges ahead of you, but you're moving into the right direction. So don't give up. You can do it. With this, we move to the next session, which is dedicated on a comprehensive cancer care network. And I would like to invite our partners from the Organization of European Cancer Institutes, Simon Oberst and Mev Nilbert, to tell us more about this work in Latvia. Simon, please.
Thank you very much indeed, Nadia, and I hope you can hear me from snowy Denmark. First of all, I'd like to thank very much colleagues from the International Agency for Research on Cancer for the great collaboration on this project, which we've been privileged to lead a task within, and also to DG Reform for funding this exciting project. And it is indeed a challenge because colleagues will be aware that the context of the Europe's Beating Cancer Plan and the Cancer Mission, part of the flagship of that has been to create in every member state comprehensive cancer infrastructures. That is, infrastructures where all the main agencies diagnosing, screening, and treating cancer come together, and researching on cancer come together in a meaningful infrastructure and an integrated infrastructure. So this is the real challenge that was placed before us to help construct a roadmap towards a comprehensive cancer infrastructure in the state of Latvia. And at the outset, we considered a few of the statistics and backgrounds of Latvia when it comes to spending on cancer care, for instance. And unfortunately, this is not a process to shame in any way, but just as a matter of record, just as a matter of the facts as they were in 2020 as calculated by the OECD, the comparative modesty of spending on cancer care in Latvia being the third lowest in the EU. Another statistic that caught our eye was the proportion of authorized cancer drugs that they may have been approved at a technical level, and we know that, but they have not achieved a financial release within Latvia in terms of approval and being reimbursed. And Latvia is quite low down on the proportion of those high-cost cancer drugs that are not covered for reimbursement. And this next slide is perhaps even more pertinent to the formation of a comprehensive cancer infrastructure, which is the availability of resources, in particular, the number of physicians per 1,000 new cancer cases per year, and the equipment, which largely relates to radiation therapy equipment, but also to screening equipment. And you'll see Latvia there down in the bottom left-hand quadrant of that particular graph, and that indicates a low degree, a comparatively low degree of equipment and low number of physicians per 1,000 cancer cases. And there are, of course, health challenges as well as a context, a particularly high degree of smoking among men, the third highest in the EU. So that is the kind of sort of context in which we were observing what needs to be required to develop a comprehensive cancer infrastructure in Latvia. And we considered this under 4 quadrants. We looked at the public health and primary care aspects. We, of course, have already heard great presentations on screening and on cancer registration. But there are other aspects of early detection that are important within cancer centers. There are oncogenetics procedures that need to be covered comprehensively as well. In the top right-hand quadrant, again, one needs to consider early and accurate diagnosis of cancer patients, the whole way in which multidisciplinary teams work effectively together, not only within university hospitals, but actually between them as well. If a patient is shared, or there are multidisciplinary teams that are shared between university hospitals, to look at radiotherapy, to look at access for new treatments and palliative care. And then in the bottom left-hand quadrant, we considered the impact of research and innovation within Latvia. We took interviews and structured interviews with the Institute of Organic Synthesis and the BMC. We looked at the whole trajectory and progress on basic and translational science in Latvia in cancer. We took evidence on the degree of development of clinical trials, and you'll be aware that there are some significant challenges around clinical trials within Latvia. Finally, on the right-hand quadrant at the bottom, in education and training, we looked at the whole question of undergraduate and postgraduate training of cancer professionals. We gave advice on exchanges and mentoring procedures. We suggested the institution, or the development actually, of a combined Latvian oncology days. And we looked at the whole question, having spoken to patients, in fact, and interviewed them, we looked at the whole question of patient information and support. And of course, all this needs to be underpinned by the effective cancer registry, which we've already heard about, and electronic health records and IT interoperability. And I was particularly impressed, and thank you, Gundas, for your presentation. I'm particularly impressed by this FHIR, the Fast Healthcare Interoperability resource, because even if the ultimate end in the university hospitals and the provincial hospitals is not to have exactly the same software for the electronic health record, this FHIR will at least be a mechanism of bringing patient data together into an integrated form. So people do ask often, well, what is a comprehensive cancer infrastructure? What do we mean by this? And since OECI has got the privilege of leading one of the Horizon Europe main actions on this question, it's CCI for EU, it's Comprehensive Cancer Infrastructures for the EU. It's a capacity building project. We have defined the comprehensive cancer infrastructures really as being not only the clinical network that you see in the blue screen, comprehensive cancer centers, smaller clinical centers, research institutes and universities, units of general hospitals, and diagnostic units. Actually, all of those are present, of course, as you know, only too well in Latvia, but also in the wider yellow box, the public functions such as public health, screening, primary community care, and population cancer registries. So it's all those things coming together. And just as a personal aside, OECI observes that Latvia is a perfect-sized country to integrate all those functions together. There are many other countries that are too big to do that, or some of them actually in the EU slightly too small to do that. But Latvia is an ideal sized country in which to achieve these objectives. So the roadmap which we designed with you, we designed with the partners, and I want to thank publicly the leaders of the 2 main adult university hospitals and the pediatric university hospital. I want to thank publicly Professor Leia and Lenice and Roland Lapuke for your help and involvement and leadership on this roadmap. Working with you, we worked in these 9 domains for action, which we'll go through in slightly more detail as I hand over to my colleague, Professor Nilbert. But we looked at all those aspects of oncogenetics, research and clinical trials, radiotherapy, palliative care, human resources, digitalization, MDTs, multidisciplinary teams, that is, patient involvement, and finally, how to form and bring together this whole comprehensive cancer network. And before I hand over to Professor Nilbert, these are the 7 key immediate actions that we recommended in March when we had the pleasure of speaking to you, State Secretary, and your colleagues in March. These immediate actions: number 1, to form a network board of this comprehensive cancer infrastructure involving 2 senior members for each of the main parties, university hospitals, research institutes, universities, and the ministries. Secondly, to address the critical need for electronic health records. We see from the presentation by Gundar that progress is being made, but we still think that significant further investment will be required. Thirdly, to start a Latvia-wide molecular tumor board led by Riga East University Hospital and Paul Stradin's Clinical University Hospital. We look forward to hearing that progress has been made on that. And similarly, a pediatric molecular tumor board, possibly at the Baltic states level, so not just Latvia. Fourthly, to establish and strengthen clinical trials units at Riga East University Hospital and Paul Stradin's, and also the Children's University Hospital. Fifthly, to finally nail down and define and agree on the minimum required treatment volumes, especially in surgery, which may require some centralization of care. We know that the professional organizations have defined those treatment volumes, but actually nobody has laid down the law and said, at least they hadn't in March, these are the volumes that we will observe in Latvia, and we will not go lower than those treatment volumes to achieve quality cancer care. Sixthly, to establish outreach teams for home-based palliative care in 2 or 3 more centres. We know that pilots have been done, and to appoint some more palliative care specialist physicians and to train palliative care nurses. That's a very strong need that is required in Latvia, which patients really underlined very closely to us in the interviews we held. And finally, to join relevant EU actions. And actually, I know for a fact that Latvia is well involved now in Crane 2, as we call it, the 90 million euro joint action to form comprehensive cancer centres in every member state. And you've joined CCI for EU, which we lead in OECI, and you've also made a twinning application. So we know that good progress has been made on that. I'll hand over now, if I may, to Mef Nilbert, and I'll change your slides for you, Mef.
Thank you very much. And from my side as well, thank you very much to the IARC, to all the partners, and not least to all our collaborators in Latvia. It's really been very interesting and a big pleasure from our side to be part of this. So I will repeat some of the things or issues that Simon mentioned. But again, it's very much around the network principles that hospitals that treat cancer, which of course includes the university hospitals in Riga, but also the regional or local hospitals in cities like Daugavpils, Liepāja, and the Sigulda Radiotherapy Clinic or Radiosurgery Clinic, need to form a stronger network. We felt at the beginning, perhaps that there were some, even maybe some competition between the centers. But also we have experienced during the project period a strong and increasing collaboration. So I think that's a very strong asset to keep up this network across Latvia. This same, in a way, goes for the institutions in research, be them the big universities or the more private research institutions, the Biomedical Center, and the Organic Synthesis Institute with excellent research. And also in this area, we feel that stronger networking, collaboration would really be beneficial. And also, of course, the need to translate or to have roads or bridges to translate findings into the clinic. So we suggest that cooperation agreements are formed, and that this network also has a board with senior representatives. And we think it's key here that the ministries of health, education and science, digitalization, and also the National Health Service are involved to keep up with the necessary developments. Cancer, as you know, is an area moving very rapidly, so I think that would be very helpful from all sides being in this together. What did we actually do? Well, we visited physically your country in 3 periods, May, October 22, and in January 23. The first one was very much a situation analysis, trying to map and understand research education. We did multiple visits, unfortunately only in Riga, across Riga, but not in the smaller hospitals. The second visit was focused on the gap analysis, provision, and also the integration. We had actually the local partners involved in workshops around, for instance, diagnostics, around palliative care, around radiotherapy, with excellent suggestions, and already there felt that there is a tremendous interest in increased collaboration across institutions and across the country. And then at the final and third physical visit, we shaped and validated the proposed actions in the roadmap and sort of aligned the expectations and checked that what we actually suggested would be relevant to the stakeholders. Between these visits, we have also collected data through questionnaires and held online meetings. So I will briefly, in 3 slides, sort of lay out a little bit more in detail the roadmap, which has, of course, also been sent to you. Within prevention, prevention is an area where all our countries in EU would probably benefit to do much more, because there is such a tremendous possibility to prevent more cancers. We say that up to 40% of cancer cases are preventable. And in this area, we would like particularly to point to the need for oncogenetic services, to provide services for these people with an increased risk of several tumor types, not least the Lynch syndrome group and the BRCA group with breast ovarian cancer. You have the skills, but the services have not really been defined yet. I still think it has linked to the Children's Hospital because of their skills in genetics, but this needs to be sort of moved out across the adult oncology clinics. In diagnostics, as Simon mentioned, a molecular tumor board, there's a great interest for that. It would also be very valuable to you. It will strengthen the networks. It would also be a way to align the discussions on testing with the national reimbursement for new drugs and the ESMO guidelines for what should actually be tested and provided. Diagnostic capacities seem to, in some areas, be insufficient, which leads to long waiting times. This is an area that may need a bit more of detailed analysis to see exactly what are the barriers. It may, for instance, be in radiology, which is, again, coming from Sweden, something that many countries really struggle with. And then the green corridor, which is the rapid diagnostic track from primary care, we think is an excellent example. So that could be further just evaluated and completed across the institutions and tumor types. In terms of radiotherapy treatment, radiotherapy, I think there is a strong potential there to have a joint, let's call it MDT or a consilium, where the radiotherapy units across the country discuss together. You are quite well equipped at, I would say, the expected level, perhaps a little bit below, but in terms of changing equipment, developing the possibilities and the new treatment standards, we recommend the establishment of a national strategic plan. There is a gap when it comes to particle therapy, proton therapy, where we suggest that you sort of define with another country or other countries the access to proton therapy, and that's also reimbursed. Current standards say that it's around 3%, so it's not a big deal, but it can be important for those patients that really need it, which is especially the children. In terms of patient pathways, we see very strong and positive developments of patient pathways in a number of tumor areas. We would just like to encourage you to keep up the good work, make sure that you have these patient pathways for all tumor types, and once they are developed in maybe one of the larger hospitals or university hospitals, try to spread them out across the country so you actually use the same patient pathway. I think that will also by itself actually foster good collaboration and partnership. And quality of care, Simon referred to the minimal treatment volumes. We did actually see that rare tumors are treated in small hospitals, which is an area that needs further, I think, attention, and making sure that irrespectively of where in Latvia you are diagnosed with, let's say, an ovarian cancer, a pancreatic cancer, an esophageal cancer, you should know that you get the absolutely best possible treatment available. Working with centralization is difficult, because the small hospitals also need to keep their skills up. But I think it all comes back to partnerships, trying to perhaps say that there are other tumor types that could just as well be treated, more common tumor types that could just as well be treated, and you could develop skills in more common tumor types in smaller hospitals. Yes, rehabilitation. As in many other countries, rehabilitation is a bit scattered, as is also the way we ask for patients' needs. So we do recommend that you implement a structured assessment of patients' needs for rehabilitation, and then an outpatient capacity. Often, this is about giving advice and recommendations for self-training, for physical activity, etc. It doesn't have to be very complex in all cases. Palliative care, again, also referred to previously, this is really a high priority area. Yes, that too many patients come into your emergency rooms and die in high cost beds within a few days, which is not good for the patients, and neither is it resource effective. So national principles, outreach teams, we saw some excellent examples of projects within the palliative care area. So we would recommend that you actually evaluate, follow up, and implement the outcome of those projects to offer better basic skills in palliative care, let's say in the local regional hospitals, but also making sure that overall there is a better access to palliative care. Patient involvement is ongoing. We would like to underscore the need of joint or same information materials, and also collect data on patient-reported experience measures. Equity of care, again, the e-health record is a key here, making sure that there are basic data on the clinical quality data, so you can actually compare across institutions how you're doing. And making sure that then these different e-health systems are interoperable. A difficult question in itself, and I know that you have a sort of middle layer where healthcare data can be transferred, whether that's the solution or you should actually go for one e-health system, which is probably where we would lean, but this is a complex question, but it's an important question for the future. HR, just suggesting activity and capacity planning, and then professional development. As a small country, perhaps a Baltic Cancer Conference could be considered. Since we actually made that suggestion, I know that the Baltic states, and I know that you're also participating, are also invited to the so-called Nordic-Baltic network of CCCs and cancer research. So It's very nice to see you there. We never talk now about the Nordic network. We talk about the Nordic-Baltic network. So that's a good development. The final slide here is on research. And I think I alluded to this before, that it's key that the research institutions form a stronger collaboration to bridge the translational gaps. There is a strong interest here from the research side. There is also strong need and interest from the clinical side. When it comes to clinical trials, this is a capacity that needs to be heightened. We suggest that you prioritize establishment of clinical trials in pediatric care, because this is highly needed. That's also an area where you could consider teaming up with all other Baltic states, not least in Estonia has this been successfully done. The early phase clinical trial unit is a sort of more long-term plan. I think more important here and now is to get the clinical trials running and professionalize that with staff education, research nurses, data managers, and sort of collect the services, make sure that all patients are considered for inclusion in a clinical trial. And overall, of course, research capacity, that's the future to better healthcare. Working with barriers such as how we can use secondary, or how we can use clinical data for research, secondary use of clinical data, and also how we can ensure that clinicians who do research have protected time to carry this out. So on the final slide, I will bring it back to Simon's slide on the comprehensive cancer network and infrastructure. So just to sum up, the national collaborations are key in healthcare as in research. The capacity building and the way you can optimize how the organizational structures work together. We suggest that you establish collaboration or cooperation agreement between hospitals, private research institutes, universities, but also include the patient organization and form a network board that keeps this together and coordinates the future work. Horizon scanning has also already been alluded to. I know that you're also leading actually the big joint action in screening, Latvia as a national partner, and prepare the Riga East University Hospital is in this certification process with the OECI, and prepare to spread it out, a network certification, look at the network standards for how you sort of need to develop beyond now the first upcoming cancer center. So from our side, thank you very much. It's been a pleasure, and we wish you the best of luck in the continued work to achieve this. I think a lot has already happened, and we can see strong potential for Latvia.
Thank you very much, Simon, Mev. Now I invite Sandra Lejnice from the Riga East Clinical University Hospital to present their perspective on the Comprehensive Cancer Network. Sandra, please.
Good afternoon. I just share my screen. Okay. As a previous speaker already pointed out, the many years Latvia was in the first or the third place in European Union, but from the end, if we speak about data about field of oncology, implementing Europeans beating cancer plan, European Union also directed the Ministry of Health in Latvia to this problem. And currently, 2 our university hospitals joined this organization. And as Professor Mev mentioned, we are in the process of accreditation of cancer center. I would like to thank all our consultants and experts who visited Latvia. And here we are with Professor Mev Nilbert, with Simon Oberst, and with Harriet, together with our doctors from all hospitals which has oncology departments, and also representatives from our patient organizations. If we speak what we are doing in this process, of course, we are just trying to do the best, and we have many problems, as you already know. And today I want to show you some things we have done. And I would like to mention that the first our goal is to go for accreditation for cancer center, and then next step will be this comprehensive cancer center. At the moment, we have already finished our patient pathways. We already have our multidisciplinary teams in Riga East University Hospital, and we also have our first molecular tumor board. In this year, in April, it is planned that Riga East Riga East University hospitals can be cancer care methodologic management center, and we will include also management of pathways in local hospitals in Liepāja and Daugavpils, and also together with University Hospital in Riga. And from the January, we opened 4 more supportive and education nurses, and we have +6 patient coordinators for our patient, which is important in the way if we're thinking about patient management and patient education. As I mentioned, we have this molecular tumor board. It was formed in February last year. And in the first meeting, Professor Zache from Zurich have lectures about new generation sequencing role in the molecular tumor board implementation steps and benefits, like example from a country which he presents, and we discussed step by step what we need to do. And in October last year, we discussed 4 cases. We have in Professor Martin Zoche from the Zurich, and also Professor Bird from Ireland. They discussed with us those 4 clinical cases, and we just starting this way to have regular meetings. If we speak about palliative care, which is a big problem in Latvia, then according to the National Health Service, from 1st January this year, the mobile palliative care teams will provide service at the patient's place of residence, which include healthcare service and social care and psychological rehabilitation service, also not only for patient, but also for the relatives. The next big problem, as it was mentioned, it's electronic health records and data exchange. At the moment, we have new project which has been started, establishment of oncology patient data exchange platform from clinical university hospitals. And it will be implemented this year, and we hope that we will exchange those data between 3 university hospitals which has oncological patients and departments for oncology. We also think about this comprehensive network, but at the moment we just working very hard for this accreditation of the cancer center. But it's a good news. We will have new director for education and science in our hospital in Riga East University Hospital next week, and we hope that he will just start with this comprehensive network if we speak about science and about these very important things in oncology totally. We also participate in establishing of cancer mission hubs, network and synergies, and we hope that this will help to make this a network board and network in Latvia. If we also join many European Union actions. We just at the moment joined 3, and we applied to join 2 of them. And we have many good expertise in this project, and we hope it will help us to make this comprehensive cancer network in Latvia. At the end, I also want to thank for the opportunity to participate in Oncology Days, which was last year in Paris. We felt like we were welcome in one big family, which are treating oncological patients in all Europe. And I think that it will help our to feel that we need to do like all people in Europe in the field of oncology. And we are also very happy that we joined this Nordic Baltic network, and our colleagues visited this network last year also 2 times. Thank you, our experts, especially Simon and Matt, and we hope that you will help in the future also to create this network, which is new for us, but we know that it's very important for our patients. And of course, we want that they are not in the place which is in the back of all, but we hope that we will be in the middle, in the Europe. Thank you.
Thank you, Sandra. With this, we are moving towards the end of our meeting, but not before hearing the concluding words from our local Latvian core team, led by Marcis Leja and Rolands Lapuke. Please, the floor is yours for concluding words.
Maybe I can start on this. And actually, I wanted to start with really thanking, first of all, the international experts. This has been a great pleasure working with you. I wanted to thank also all the participants from the Latvian side, because as you can see, we are a great team currently here, either here in the room or online. And I have to mention also that all the experts from Latvia have been participating in this project in their free time. So I appreciate this involvement from everybody, either from institutions like National Health Service, CDPC, and also the Ministry of Health. And actually, when starting the project, we were a bit not very comfortable that this will not be another expertise project where the results of the project are getting or lying on the shelf in the Ministry of Health, and nobody is really following the recommendations. And we do have usually a lot of excuses for this, because funding is usually not enough really to realize. So it is really easy, and that was also honestly a concern from the Ministry of Health. And now what we have been discussing also with Rolands, that the results of the project have even exceeded our expectations in the very beginning. And even though the European Commission is not funding the implementation of the recommendations, but the implementation has already been started in parallel during the lifetime of the project, and we are really comfortable currently in the current situation that the implementation will be actively ongoing, and we are going really to achieve the results what have been set. So thanks once more for everybody for involvement. Thanks to European Commission, to DG Reform, and those people that have been involved in consulting us when putting this project together, as well as Simon and his team, who are responsible for the project right now. And we are quite sure that we are going to continue this collaboration with all of you and many others also during the upcoming project. Thank you.
Well, I won't say so many thank you that Marcis said, because I joined your thanking. It was a pleasure to meet everybody. I learned a lot. And I think the greatest pleasure was to see that at the end of the day, all stakeholders in Latvia were at the table. And this is, I think, what we have to pursue. I have one remark. It is that I always said a good idea is not an idea that is solving everything. It's an idea that is coming at the right time and it's feasible. And what I am convinced of is that everybody knew in Latvia that we need an oncological register, that we need to put order in screening, etc. There were activities, but I think this project has very much helped everybody to put the whole system together and all the brains together. And the Ministry of Health, especially IGA, has been very active in doing that. It has been taken over by the ministry. So this is exactly what it had to be. It's you helped us. We need energy from outside sometimes. It's like in entropy. You need some energy from outside to understand how to do things and say, well, I have no choice. I have to do that. This is what has happened. I am actually even very proud of what we have been doing, everybody together. So thank you very much, and I would be ready to start again now that it is finished. Maybe.
Aiga, would you like to complement these words as well?
I actually could take my other hat as I'm representing Minister today as well. Minister Hassam Sabomeri is fighting again for the finances and additional funding, and he's very active. And I took one phrase from him when I asked once his advice, and it was on digitalization and on change management. And he said, stop lingering. If you know where to go, go. And when you go, be there. And I think it's for us, the point when we know how to go forward. We have approved with this project that we're not lingering in cases when we know where to go forward. And as I said, I have this festive feeling today. And outside it's very dark and gloomy. So I admire, Simon, in Denmark that you have snow outside. But I think the spirit is very enthusiastic. And I think you won't be able to stop these people. So if I start writing to you complaints that my colleagues are too active, please take them as experts someplace else. I hope you hear me then, because I think you are sitting today in the room with experts who will shed the light, who will be the bridge builders. So I have been really delighted to be part of this excellent team, not being doctor, not being healthcare specialist, but when I see that Latvia currently has palliative care provided by the state and so many other things happening over such a short period of time, I say Latvia can and Europe can. So look for experts from Latvia joining you in other actions and competing for the best for Europe and for the world in general. Thanks a lot. Thanks for being patient sometimes, for us being the bottleneck for the answers. But as I say, the knowledge is here, the expertise is here, and the time is right. So keep the fingers crossed that all the recommendations exceed the time limits. We have done them sooner than promised. But at the same time, I also think we are for the quality, not for the speed, but for the quality. And I have been here getting nudges from Professor Leia and vice versa. And I think there's so much to do also for the public awareness. There have been so many opportunities. We have to nudge people to respond because we are building, as Marta said on the first day when we met, there's a need for a holistic approach. And I think it also corresponds to Simon Overs when you said that comprehensive approach. So watch out for us and stay in touch. Thank you.
Thank you. Really great. We are also privileged to have Iris Landers-Bogelard from Erasmus Medical Center as a consultant to this project. Iris, would you like to share your impressions from the work?
Yes, thank you very much, Nadia, and thank you very much to the Latvian team for all their work. Listening to the presentation, seeing what has been done already, but also seeing that there still is quite a few steps to take. I'm very pleased to hear, I cannot see the faces in the room, but to hear from Aiga that there is a twinkling in the eyes and that people are ready to go. I think the only advice I can add to all the advice that has already been given, do not look at the full stairs, but take it everything, all the recommendations step by step, because every step is a step in the right direction. And eventually you'll get there if you take it step by step. So if there's anything that after this project ends we can help with, please reach out, because we're more than happy to give our advice or connect with people that may have better advice in these respects. And I've really enjoyed the collaboration with everybody. So I'm sure we'll be in touch, and I look forward to seeing the great things coming from this program.
Great, thank you. Simon Dres is also with us from DG Reform. Simon, the floor is yours for concluding words.
Thank you. Thank you, Nadia. Well, I mean, everything has been said, I think, so I will just say really thank you to Marcis and Roland for their vision and ambition in applying for this project. More than 3 years ago, I only had the pleasure to join you in 2022, but it's really been an honor to work with you, and we are grateful for your trust in us and in the technical support instrument, in our ability to support you. And it's been a great pleasure to work with all of you and with the IR colleagues and OCI colleagues on this project. And let's end on this very positive note. It's a very nice spirit. Yeah, that's really all I wanted to add. And I think now Andre will close, right?
Andre, please.
So I'm really happy now. It's kind of, I think this is a really nice closure of this project, right? That starts with a lot of conversation, with a lot of discussion how to implement, and took a while until we really started. But we can see 2 years down the road how much have been done. And it's true that when the country request, the TSI is as an important matter, and its shortfalls have been identified in the country, right? But Latvia was so eager to make the necessary changes and improvements that by the time that the project started, some efforts and changes have been already in place, like the planning for improving the cancer register, or the process for the Riga East University Hospital to be accredited as a cancer center, but it's still not for all necessary matters that have been approached. So it's fulfilling to see that many of those changes have started during the project, and it continues to happen, as the project kind of acts as this catalyzer, as this facilitator, so that outcomes, the impact of the project can be achieved. So this is a really, really important day, and a happy day for me, when we can be part of the change, and and that we can see the local stakeholders to take in the ownership of the project, because this is important. This will not happen. The change will not be implemented if you don't see this as a Latvian project. So we have been just the catalyzer and the facilitator, and I'm really happy to be part of that. And I guess everybody on our side, is also happy for that. With that, I would like to thank again all the stakeholders in Latvia, and in particular the Minister of Health that gave the support and made the necessary changes in policies, and is fighting for the budget to implement all the improvements, in all the cancer care continuum in Latvia. It was a pleasure to be working with you, and you can count on us for the next steps in that road. Thank you so much.